So, hello everybody. Today is March's 2021 Housing with Services team meeting. Happy spring to everybody. This first Monday of spring. It's not wanting to forward my slide. Oopsie. Okay. So, as is our tradition, we will start with a prayer. I picked a prayer for patience right now because I feel like all of us are feeling, we're vaccinated, COVID's on its way out, but yet we watch the news and we see these other strains and we see Florida and we see all sorts of things. So I kind of felt like I needed some patience right now, and some, hope in the future that it's almost there. So that's why I picked this prayer. So please center yourself and join me if you so choose. Prayer for patience. Grant me patience, Lord, as I await your answers to my call. Teach me to be still in the midst of the storms, for your timing is always perfect, never too early and never too late. Knowing that you hold the future, it is definitely worth the wait. And for all of us, I hope that our wait is very short into the future for our life to return to normal. And thank you for all that you guys do in our life of lack of normalcy at the moment. So today, kind of the long awaited, we've been talking about this for a long time. Denise has talked to the culinary directors. She's talked to we've talked to the directors of nursing, and now she and hopefully Evans is on the call as well. We'll just kind of wrap it up and tie it in a bow to us. So I'm going to turn it over to Denise, and I can be your Vanna if you would like me to, Denise. And she's going to talk about culinary, and then after that, just going to give you some more information on diets, information from Dr. P in a new letter. But in 1 second, we'll start it up with her. I do just want to show you as she talks.
Annie?
Yes.
You're kind of fading in and out. You're hard to hear.
Oh, okay. Well, while she's talking, I'll switch speakers. Thank you, Jerry. So as Denise is talking, just so you know that after this presentation, if you want to find the information, it's also under culinary. We decided to put it in 2 spots here. It is in the library under the BHS Support Center, housing, and culinary. And you will find all the tools that Denise and the clinical team have created for us. So Denise, do you want me to give you the screen, or how do you want to do this?
Yeah. Yes, well, let's share the screen back to me. Thank you.
Yep. Stop sharing. Okay, take it away.
All right. 1 second. All right, good afternoon, everybody. Is everybody able to see my screen here?
Yes, but it's the edited version, not the PowerPoint. There you go. Now it is.
Okay. All right. Well, thank you, everybody, for joining. Feel free to ask any questions as we go through this. We really want to introduce, spend some time talking a little bit about altered therapeutic, altered texture diets in housing with services. And our goal is really to be able to say yes if there is a need or a desire for residents on these altered texture diets. So what I thought we would begin with is just kind of setting the groundwork. What is a mechanically altered diet? And this definition comes specifically from CMS, and it would be defined as any diet where there are altered textures as far as the solids, could be pureed, it could be ground meat, thickened liquids. It is a diet that is not considered to be a therapeutic diet. That leads to the question, what is a therapeutic diet? And again, a therapeutic diet could be something that would alter our nutrients related to a health situation. For example, altering carbohydrates for diabetes, altering protein for a renal diet, sodium for cardiac. Those would be examples of a therapeutic diet. Altered texture modification, some of our priorities when it comes to nutrition is to prevent unintended weight loss. We want to honor quality of life, avoid malnutrition, of course, and make mealtimes enjoyable as part of our daily activities. So what has changed? Why is it possible now for us to provide altered texture diets in our assisted living or independent living situations? In my opinion, a giant leap forward has been our ability to offer the tools and resources through our software program called MealSuite. And MealSuite allows our culinary directors and the culinary teams altered texture recipes, diet extensions, all of the information and tools for our culinary folks to be successful in providing these diets. The other piece that I, of course, appreciate about the software is it does offer us the ability to provide nutrition information. So if a family member had concerns about calories or sodium as a part of a diet, we are able to provide that information, and that can be part of the medical nutrition therapy back to providers if there were questions about protein content for dialysis. We've really got all of that information provided to us. And here's an example of what that looks like. We can do an analysis based on a month, based on a week, based on a day, based on a specific meal period. We can drill that down any number of ways. Just the other thing I like to point out to folks, and this is not specific to altered texture diets, but Benedictine does have a annual subscription to the Academy of Nutrition and Dietetics. It is our nutrition care manual. And every healthcare organization is required to have a diet manual that we follow so that we are all using the same best practice clinical guidance when it comes to therapeutic diets. And so Benedictine is using the nutrition care manual from the Academy. This resource is located on eSource. So anybody could access this nutrition care manual. It's frequently used by our dietitians, but it is a great resource when it comes to education, again, that family members or residents may request. So they may come to you and say, could I have information about low sodium diets, or how do I manage my calories when I'm looking at a weight management program? Great tools and information. This is examples that we can get handouts and provide really consumer-friendly guidance when it comes to therapeutic diets or just general information. If somebody is wondering, you know, how do I eat healthy on a budget? How do I monitor my sodium intake? These are great resources. So the next thing I'd like to introduce everybody to when we're talking about altered texture diets, this is a significant change that Benedictine is in the process of converting to. If you haven't seen this already in your community, it is called IDSE, which stands for the International Dysphagia Diet Standardization Initiative. That's sort of a big mouthful of words, but essentially what that means is every country has agreed to standardize the terminology and the testing for altered texture diets. So we're all going to talk the same talk and use the same criteria when it comes to following altered texture diets. The Academy and the American Speech Language Hearing Association are both in joint support of following IDSE. And as of October 2021, IDSE will be the only texture modified diet recognized by the Academy of Nutrition and Dietetics. So the previous terminology of dysphagia diets will no longer be recognized. And sort of these pyramids, we've got the liquids and the solids. These are the colors, the terminology that we use for describing these food and fluids. So why IDSE? Again, it provides standardized language All countries really are agreeing to follow this terminology. It has proven testing mechanisms, and it allows us in food service operations and our manufacturers to be all talking the same talk when it comes to these diets for safety, quality, and consistency. So again, just a quick review. The NDD was what most communities were following, which stands for the National Dysphagia Diets. And we would talk about nectar, honey thickened, ground, soft, all of that is going away. And our communities are all in the process of converting to the IDSI crosswalk or terminology. And the reason I'm kind of going into this a little detail is because when we do accept residents into our housing communities, we do want provider orders that are following the IDSI terminology. So whether we are on the skilled side or the housing side, we all again want to be talking the same talk. This is standard language. Acute care facilities are converting to the IDSI, and so we may receive residents from that with those diet orders from an acute care facility, but it's really the best practice and recognize that this is the right diets. The biggest change that we see in converting to these diets is that bread is not allowed on the levels 4, 5, and 6. And that is a significant change. Bread is a very difficult food item to chew and swallow if we had any impaired chewing and swallowing. So it is restricted. And I'll talk about some options when it comes to that. But I point this out because some folks may say, well, why didn't culinary serve bread? And it's not that there was a mistake in that regard, but it is really an item that is not allowed on these diets. Again, bread requires softening with the saliva. It becomes difficult to move around, and it can become a choking hazard. So what I'd like to just share, there are really two options that the culinary team can be following when we are preparing these products. We can either purchase commercially prepared products, and there are a number of really excellent products on the market for fluids as well as foods, or folks can prepare their own. I'll talk about that in a minute. These are just an example of some of the products that folks can purchase and use. I like to show these because many times we think pureed food, we think about, just food that isn't attractive. And we really want to be cognizant that, our quality of life and making sure the food items look as well presented as possible. The other option communities can do is, and we really do need what we call a RoboCoupe, which is really a fancy blender, and we really do need this piece of equipment if we are going to prepare the food items in our community ourselves instead of purchasing. So just to kind of show you an example of some of the different levels, I want to give credit to our CODA community in Owatonna. They have implemented IDSI and they're doing a fantastic job. Michelle shared these photos with me, and I just think they're a great example to kind of point out some of the differences. So here is what we call IDSI level 4, which is the pureed texture. Everything is smooth, consistent, no lumps and chunks. The minced and moist level 5 is going to have a little more texture. And I like to use the analogy, if you can visualize what a fork looks like, the tines of the fork are about that 4 millimeter size. That's some of the criteria. The food at the level 5 should be about the size of the tines of the fork. And then level 6 is a little more advanced. We call that soft and bite size. And again, if we think about a fork, a dinner fork, the size of that fork is about 15 millimeters, and that's really about the size of the food particles that would meet this criteria for level 6. Should be very soft, mashable by a fork, but in a larger size. And then of course we've got the regular textured diet. And as we go through those various levels, of course, we want to honor and respect resident choices. We know that residents, they have the right to refuse treatment. It's really important that we document all of that, choice as we would in a skilled side as well as an assisted living side, that we, provide some education and document that it is their preferences. We do have orders that we can follow, and I won't go into all this detail, but on the skilled side, and my understanding is we can implement some of these order sets on the assisted living side as well. But I just pointed out that we do have a process in place so that if you are accepting a resident on one of these diets, we do have order sets. Here's an example of what the texture order set looks like.
Denise, I'm just going to stop you for a second to remind folks, if you are not on mute, please everybody check and make sure you're on mute. Thank you. Thanks, Denise.
So if Evans is on, I'm going to let Evans kind of speak a little bit more to some of the nursing evaluation that occurs.
Thank you, Denise. So as Denise said, the goal is for us to start admitting these residents. And I always bring this example. We are in housing. We have residents mostly moving from their homes, coming to our facilities. So the question comes, if somebody has been taking these meals at home, this kind of altered textured diet, why are we saying no? That's why we are moving to this different way of looking at it, that they are basically moving from one home to another. And since we are going to provide these services all overseas one way or another, we just want to make sure that they are still taking what they're supposed to. So essentially, we want to have good assessment being completed. So nursing, we have to complete the assessment and ensure that we are able to meet the needs of these residents. During the assessment, this is the time the nurse will make that decision if you can meet the needs of these residents. Because as we know, there are so many levels of care for these people who take special diets. So at that point, if let's say your community is not offering meal assistance in the dining rooms, so then you may want to look at that. How are you going to meet the needs for that specific resident? So good assessment is really important, and it will guide us to make a decision if we need to proceed. Next slide, please. So then once we know that, then all we need to do is good communication, because we want to make sure that both the culinary department and the nursing know what this resident is taking, so that this will be providing the needed diet. So once that has been communicated, then the next thing is to review the policy with all staff and educate them. The policy really is, the goal is to recognize and understand the diets we are providing for these residents. Do you want me to share the policy, Denise? Or you have it?
Oh.
Are you there?
Sorry, hang on. Can you see it?
Yes.
Okay.
So like I said, basically the goal is to make sure that staff or associates understand what this altered textured diet is, as Denise explained. Once they know that, the next thing we want to make sure that they know is, how do we recognize that somebody is going to choke or is experiencing swallowing difficulties? So that's the whole point about these policies. Once they know that, then we have, again, this is dependent on how you guys staff, but we will require licensed staff to come and provide emergency help if it's needed. Otherwise, we are asking the 911 be called. So basically, that's what this policy explains, making sure that staff are educated, they know what signs and symptoms are for choking, and they know where to respond to. Any questions on that?
Okay.
So then the next question is the dignity of risk. So last time we had this with another group, there were questions on who is going to make sure that these residents are taking what they are supposed to. The question is easy. The question is simple here because these residents, they are in their homes. Our job is to educate them and to ensure that they know what they're supposed to, but we cannot police and make sure that they are taking what they are supposed to in their rooms. So our goal is to make sure that whatever we provide is going to meet the recommendations from the providers. So, and we have educated them, they understand what they're supposed to take. So if, a family member comes over the weekend with a different kind of meal, we will not be able to know. Again, that's not going to be part of us. As is, if they come to the dining room, the dietary aide must know what they're supposed to give them so that they don't give them a different kind of meal. And now it will be very hard for us to address that because we are supposed to understand and know what we're giving them.
And Evans, there is a question for you, sir. This is Krista from Humboldt who wants to know, does this mean that we need nursing in the dining room?
No, we don't. That's why we are saying we just need to educate staff to know the signs and symptoms of choking and people are experiencing difficulties. You just need to read them. Once they see that, then they either need to call the nurse in the building or 911. So we don't need to have a nurse sitting in the dining room.
Krista and others, this is Jerry. I think it's important that when we provide modified diets in the AL, the resident understands it's communicated during the admission. And if we would bring somebody on with a modified diet that's already residing with us, is that we do not have nursing staff 24 hours a day in the dining room, and there will always be some staff in the dining room, but if choking happens, there's less risk of choking if you have a modified diet, if you have a risk on that, but there still is the risk that you could choke. And we would get help 911 just like if you were in the community.
And I think that is the biggest question that I hear when I go into the communities and talk about this is we don't have and I'll show you some additional tools that the clinical team have made regarding that. But it's our job to assure that they're safe, and I can't do that if I don't have BLS certified 24/7, if I don't have nursing 24/7. So I think what Jerry and Evans have just said is really important, that especially in housing, this is not an institutional setting, this is their home. And in their home, in your home, in my home, if I ended up on a modified diet tomorrow, I would need to learn to manage that. And therefore, their ability to manage their diet in their apartment or in a dining room or in a whatever, we are providing them the opportunity to manage their own diet in their own home. And that is advocating for their rights as a human being, which is our job in housing. Anything you would add to that, Evans or Jerry or Denise?
I think you put it right, Benny, and that's what we are trying to educate all the leadership in housing. That just look at these people as people moving from their home to another home, so that we don't start bringing so much restrictions to what their rights really are.
And I think another example that I've seen of that is, when we talk about diabetics, they in housing, we give them choices, but they still need to manage their own diet. And if they have an apartment full of Hershey bars, that's their choice, that's their right. But we have given them a healthy diet in which to choose. And this really isn't a whole lot different than that. So Denise, your PowerPoint said questions. So do you have other things that you want to share, or?
I just wanted to point out, if you can see my screen, there is an Educare course called Menus and Diets, Therapeutic Modified Textures. And this is a course that can be assigned through Educare, and it's a really great introduction, not only for culinary, but as well, resident assistants, nursing staff, to be introduced to what altered texture diets are. There are 2 courses. Each course is 17 minutes. And I would recommend this course if this is something new to your community where you're introducing altered texture diets for the first time. It's a great way to show that we've completed the training and we have that record of completion in Educare.
So Denise, I have a question. So if you're using the RoboCoop, how do you make it look nice like that? Or like the food you're serving?
Yeah, I mean, it's a great
Mold.
question. There are some garnishes and sauces that we can try to do that to make that look attractive.
There's also molds you can get where it depend on the consistency of some of the little bit less liquidy foods you can mold.
Right. It really depends on the comfort level of your culinary team and your staffing. Personally, I like to recommend the frozen convenience items because they're consistent, especially if we're having any staffing challenges. They really are nutritionally adequate. They're very good sources of protein, and they're very quick and easy to serve. They do not require a lot of labor. They are going to cost a little bit more, but balancing that out with labor. So it really will be an individual assessment on that culinary team. But I just think it's important to know we have options and really good products available so that, again, as Jerry and Penny and Evan said, we want to be able to say yes from the culinary perspective and support good nutrition for the residents.
Right. There's a question here that says, and I think this is maybe Nina Herbert, I don't know everybody's name, but when resident comes to the dining room on a modified diet and choose to order outside of that diet, are we as staff supposed to fulfill that request? And I think the answer I would give is yes. I mean, this is with alert, competent residents. We're not talking about dementia care here. We're talking about alert, competent residents. So if they choose to take a food that's off of their diet, I would say we give it to them. Evans?
Mm-hmm.
Yes, because they have the right to choose what they want. Again, our documentation should show that we have educated them and they understand about the complications that can come out of that. So we need to do our part and then respect their rights.
So Denise or Evans, I mean, to the point that you just made as far as the documentation, when the group discussed this, we said that we would only provide this if there was nursing oversight. Therefore, they would need to be in at your service and or AL. Do either one of you want to talk about that decision?
I would say because nursing is going to be involved, one way or another, nursing will be doing assessments for this resident. So I don't know if we can say that they will be without services if we are monitoring, if we are doing the assessments. I don't know how we can separate that.
Yeah, I think for sure in AL, I think at your service becomes difficult depending on if the dining room has staff in it. I'm just not as familiar with that, but for the AL for sure.
Yeah.
Because you have to do the assessment of that individual. I am working right now with our matrix team, Shelley and Linda, and then legal counsel to see if we want to create a observation that is discussing when, and this is not just one of the risk benefits that we become aware of. We have the resident that is supposed to use a walker and walks in the hallway all the time without a walker. You know, do we want to have a document, a standard documentation form that states, we talked about this with the resident. They understand these risks, benefits have been communicated to the resident. And then that goes as part of the service plan. That's not quite ready to pull the trigger on yet, but we are working on that.
But I think the point being that for all the reasons that was just discussed, we would want the persons who are on modified diets to be under the care of a nurse, where the nurse could do the assessment. There's another question here from, I think it's from Lynn Kern. So speaking of memory care residents, that is likely where the need will be in our facility. So how will it work if we note that they are not wanting to eat the altered diet? Do we give them what everyone else is eating around them?
What do you do currently with diabetic residents in memory care?
Lynn, can you unmute yourself?
As she's unmuting herself, I wanted to add this on that. Assessments basically guides nursing judgment. We have somebody who cannot tell us where she is, what she's eating, it means that we are directing what is happening in our life.
Not on the phone.
I think maybe what Lynn is talking about, some of our memory care residents do request other things that they like, and they want to eat what someone's eating next to them. Being that maybe they're confused, but able to make some choices, are they going to go ahead and serve what they're requesting, knowing that that is against their diet, or are we going with their wishes? I think that's what Lynn is trying to get at.
I think there's a whole different ball game that I don't think, Penny, we've fully discussed, if you would agree with me. When we have people that are not able to understand risk benefits, you know, I may want something, but if I have cognitive deficit, I may not understand and be capable to truly understand what I want and the risk benefits. I'm thinking of my 4-year-old grandchildren. And not to equate adults with children, but I do think we haven't fully talked about that, Penny. Would you agree with that? That maybe we should have the team get together before we go any further with this?
I think that's a good idea, Jerry. Lynn did respond, I'm not on the phone, but we are serving meals that are provided by the extended care. So I think, yes, maybe take that back to the team a little bit. I guess I would answer in a little bit different way too, is if you've got somebody who's in memory care and they want what the neighbor has, or they want what's in the neighbor's purse, or they want what's in the neighbor's room, we redirect. We re-offer something else. Well, instead of taking their stuff, how about if I give you something for you? So I guess I would again say that, the good nurses that I trust in the world would look and say, is that a sound judgment where this person is really doing that? Or is this an opportunity to redirect because this person really is not understanding the ramifications? So I agree with you 100%, Jerry. I think we maybe need to take it back and kind of weigh that through the risk type thing. But at the surface, I would say, we redirect all the time to the appropriate decisions for memory care, and in simpler forms, maybe that's an opportunity.
And I think sometimes seating people next to people with the same diets or, the same habits, I think there's always a workaround when you have those one residents that are a little bit more challenging. So,
and I think it also helps if the food looks like what it's supposed to be. So we've got another question. Due to resident rights, the family would update and the resident would be served what the resident wants. If the risk is high, hospice. Good point, Oda.
Yeah, I'm not sure I would go to hospice just because the resident wants to eat a non-modified diet. let us take this, we were looking, when you think about the dignity of risk as a concept and Neil, that's Neil's contribution to this, Neil Budenseek, the dignity of risk assumes that you have the capacity to understand dignity or risk. So I think we have to go back to the drawing board on dementia care. I think, and we'll get back to you with that, guys. I think the other thing is this is a decision you make, but we want you to be able to give care to people. If you think about someone who simply needs a modified diet and they would have to go into nursing home, would that be the right choice for them?
Right. I remember when we first started looking at this, there was a director of nursing that said, I've known this man for 20 years. Don't tell me he has to leave just because I have to cut his hamburger. And that was very telling to me in how she stated that. So I think, looking at that aspect. So that question, as Jerry said, we'll take back to the group and come back. Denise, I want to stay on the modified diets, but I want to show a couple other tools. Anything else right here, Denise, that you would?
There is another question from Herbert. A diabetic diet and modified diet are two different things. Yes, they have both are serious in their own right, but a modified diet has a higher risk of choking if not being monitored correctly on a regular basis. I'm not, just something to consider, and I thank you for that. Both have high risk, and when it's just people who are not in an institution and there's not regulations pointing to a certain way have the right to do things that may cause risk to self as long as they are well informed.
I agree with Jerry. And sometimes if we are looking at this resident to a specific clientele in our image, then we are able to ask ourselves these so hard of questions. But we are saying somebody has been doing this in his home. Now we are telling him you can't do this or you have to go to a nursing home because we can't allow you to be here. So think about the kind of clientele you are imaging as you are thinking through all this.
So Denise, can I take the screen back, please? And
Yes.
Thank you very much. Okay, what I'm gonna bring up, yes, okay. To this point in this discussion, in the admission documents that Minnesota has and the other buildings are being created, this actually should be rolled out, not through the admission documents, but in other ways should be in every state. This is the letter that goes with the advanced care planning documents, letting people know that we want to know their wishes, that we encourage the pulse, whether you're IL or AL or memory care. And in this letter, this happens to be the one for independent living, it is very clear in the old form and in this new one, if you can see right here, it says, if you're ever found to be severely choking, EMS will be called and basic life support for relief of choking will be initiated whenever a BLS certified nursing associate is available and physically able to do so. Now, it has always said that even in the same thing here, with CPR, if you are at risk of having a heart attack, and if you want to be a full code, please know that we would like to honor your choices, but we do not have someone who is basic life support certified within the building at any given time. So we would need not only that person to be certified, but another person who could go to the door and let 911 in. Otherwise, our only option is 911. So again, as that nurse has that conversation, as that nurse talks to the person and they understand that they're living in an assisted living and not in skilled care or not in a hospital or not in whatever, this is assisted living. This is what we have available. You come here with risk. We can support you at some level, but we do have limits in what we can provide because we do not have BLS persons in 24/7. So it has one for independent living, it has one for assisted living. It's always been there, but now we've added this release of choking so that people are aware. So any questions on that? And I think, again, that goes to that conversation to have and then allow people the option. Again, remember, even if we're assisted living, we are under fair housing. We have to make reasonable accommodations to people to live here. So we let them know what the risk is. If they say, I want to live here under fair housing, this is a reasonable accommodation to advocate for their rights and not to take them away. So that will help us to explain that. The other thing that I wanted to share, and I'll just stop and look at the chat box. Were there any questions on that letter? So we'll have Lisa, we'll send that out, and then we'll also have Lisa change it for the folks who have their admission documents already uploaded to eSource. I can't see the chat box. Any new questions?
No, Penny, you're good.
Okay. The other thing that, as Denise was talking, if your dining wants to do this and you want to use the RoboCoop, please make sure you put that into your budget and ask for it in capital. How much is it, Denise?
They're approximately 1,500.
And then the other thing is, as Denise recommended, that it comes in those pre-packages formulas. So Denise and Jerry helped to identify how much these meals are costing, and based on that, we created this little document that is also on eSource. So if you want to offer modified diets on a regular basis, this is what you would add to the cost of the meals. So you can either do it as a separate pricing sheet, or you can just update it by sending this to Sarah and asking Sarah Mueller through WorkZone and asking her to update your rate sheet. So the thickened liquids plus the modified meals and snacks for assisted living would be about $300 per month, or would be $300 per month. The assisted living modified meals and snacks only, so without thickened liquids, would be $200 additional per month. And in independent living, again, you would need to be on at your service or under the care of a nurse. So this would be modified diets can only be accommodated by ND order, which requires enrollment in at your service or under Benedictine nursing care. And again, our ILs, typically we bill per meal. So this would be the cost per meal. If they chose to do a meal package and you offered those, then you would use these rates up here. Any questions there? Okay.
You have one, Penny. Lynn is asking, is this strictly for meals, or would this be for therapeutic rec activities as well when we resume having food during activities?
Yeah, we did. Denise and I did talk about that, because I said, well, what about exactly kind of some of the snacks? What about this? And we felt like we would basically include that within our overall meal cost. Because
Yes.
it'd be too hard to pull that out. Would you agree, Denise?
Yes, agree. Yep.
So it's kind of baked in here.
Yep.
Any other questions? Well, I have to tell you, I was on not all of the calls, but I was on quite a few calls. And I know that Jerry and Dr. B and Denise and Dale and Evans and others have worked really, really hard to wrestle this through. This was not done lightly. This was done with great thought, lots of tools, lots of resources to really allow ourselves to empower people the rights that they have through their life and to have the best in quality of life. And I thank all of the team of people who created this opportunity for the residents we serve. So thank you. All right, so I'm gonna try to, my toolbar is in the way, so I can't turn this into a PowerPoint. Slideshow. There we go. Okay, can you see my slide deck again?
Yes.
All right, so pending any questions, again, thank you guys very much. I would recommend, again, seriously consider this. There is no reason that we cannot do it. It is the right thing to do. And as you look at this, how to train staff, how to prepare for it, Denise is there, lots of tools. And then again, I would recommend marketing it. There are people who really want to live in our communities and would really like to know that we have this available. So when you have this available, when you feel ready to move forward with it, I would make sure that the world knows as well. So next, just an FYI about long-term care insurance. So in the past, our communities, if somebody had long-term care insurance, I'm not aware that anybody actually billed it, but we would help people fill out the paperwork for it. Often what I'm learning from the CBO is this paperwork is more about census. When were they in the building? Are you in assisted living? How long have they been there? It's pretty simple. And the CBO is willing to do that as a courtesy for folks to make sure that we can accept persons with long-term care insurance and that we can help them get paid. So what we'd like to propose to you all is that, you know, if somebody has long-term care insurance, tell them, yes, we can help you with that. Make sure the CBO needs it. And then the CBO, if it's simple, will fill it out. If it does require going back for a nurse to put in clinical information in order to get it approved. So in other words, if there's anything to be done at the community level, we would charge them using our nurse a la carte charges. So whatever you charge for that 15 minutes for the nurse, however long it takes that nurse to fill out that form, that's what you would bill. Any questions on that? Okay. Next. Resident satisfaction survey. I don't know if Jerry's still on, but today is the deadline. So just wanted to remind folks that you are supposed to be turning your satisfaction surveys for your assisted living residents to our support center in Duluth. Anything?
Yep, and if you need more time, we're pretty relaxed with this go round. You know, just send an email to Key. We're meeting, I think, Penny, next week to work on how the reports will look. So it's going to take us a little while to get those back out to you, but do get them in as soon as you can and keep Key alert to what you're doing so she knows what to expect.
Okay, any questions on that? All right, finance. So I need to.
I don't know if that was intended to really be a press release. It's more for, you know.
So somebody's talking about a press release. Okay, so here's the finances for February. I did send an email to Kevin when I saw this, why is it not showing here? The $17 million loss here. And Kevin did say that that was a mistake. I think it has something to do with the COVID dollars and just got put in strangely there. But anyway, so if you look at year to date, this is with the COVID dollars that we have. We are still ahead of budget overall. This is operations actual year to date. We are at $2 million. So we're still almost $500,000 ahead, though we did lose $200,000 with the COVID money in February. So it's time to do the best we can to get life back to normal. As we have talked about every single month, housing with services, you can see that it's just a little tiny bit higher than last month, which will take it, yay. But it's not quite there. We need to get it back up. And this line right here is our budget. So we got a ways to go. I know how hard you guys are working at it. If you look down here, again, here's for the system. Again, head variance $5 million with the COVID dollars. This is without. You can see a very different picture here. This is where I think the 17 million is supposed to be. And then again, we're $2 million off. And if you just look at the operating income, we are $7.5 million off. So the COVID money is definitely appreciated. And if you haven't gotten enough reminders on that as well, whatever you can do to help track to make sure we can keep every single penny of that is critical. So again, performance, $2 million off, but still ahead of budget here without COVID dollars by 163,000 by the chin of our Chenny Chin Chen. Looking down, just scrolling through again, I always try to highlight this so we're not having to go through too much of the detail here. Again, here's our, this is our overall budget. It doesn't break it down to housing, so I'm just switching past this. Again, this is our overall budget without COVID. Now we're moving into the housing. As you scroll down, you can see the census. It's all about the census. And you can see in total, we're at 83.9% on a budget of 94%. Again, financial summary, these two lines right here being the housing with services. These are our ministry partners. A loss of 1.4 million on a budget of 684,000. And scrolling down, bringing it down to housing. Again, our ministry partners, a census of 79.3 on a budget of 90.7. And still positive, but 19,000 as opposed to 380,000. And you know, you can tell again, it's all about the census. Without COVID, that doesn't change our census. But again, without COVID, a loss of 179,000 on a budget of 380. So COVID is definitely helping housing, and housing is the one that I talked to many of you, and I know finance has already got this covered, but oh, we didn't spend anything. You know, what just think very carefully about it. We spent a lot. And so whatever you can do again to help keep those dollars, we really need them. Any questions on that? All righty. Move this over. Let's go to eSource. Sorry about my dog. All right, so safety index, again, just reminding folks, this is falls and medication errors. Satisfaction, we'll have an updated one soon. ALF recommend, we'll have an updated one soon. Associate engagement, that is, again, a once a year measurement. But the retention is green. The associate retention, our 90-day and 12-month is green, so that's great. Time to fill is close, but yellow. Bad debt, yellow. Consolidated cash flow, yellow. And cash flow in AL is red, so a little bit low. So something to work on as a team to get that measurement up. Questions on that? All right, it's time for our Linda Matrix update.
Hi, everyone. Just listening to this, I thought we'd kind of maybe go back over where we can put this information about the modified diets. So when we're looking at our Care Assist banners and our aides here and what they have to do, when we're looking at their diets, the diet does not pull over to the banner, but the administration instructions do pull over. And so I believe that's in all of Care Assist users, any facility. So over under the resident, under their order page, when you want to do any administration orders, you can edit that and you can put in anything that is needed, whether you're crushing meds or what kind of specialized liquids can go in, and that will carry over from the order page then over to the banner and Care Assist. So then if we go down to Lois here, you can see then the aides will know what kind of liquids they have or what kind of diet.
Are you trying to share your screen? Because I don't see it.
Oh, did I just not even do that? Oh, sorry, hang on a second. That would be helpful, wouldn't it? Okay, can you see it now?
Yes.
Okay. So again, back over in the order page, under the resident orders, there's a place here where you have administration notes and information. And you can edit that at any time and put in those modified diets here. And maybe if you have crushing meds or any likes or dislikes could go here. I know some of the communities have already started using that. As these banners expand, Currently in Care Assist, when we look at the person's banners, we don't see the diet. It doesn't pull over yet. So that would be a great place to put it under that administration instruction. And then of course, the assessment is already in the service plan. So just for review in your service plans under nutrition, the aides can always go in here and read what their diet is at any time. And I'm out of order, and I probably didn't answer the question on this one. I did not on her. But the questions are in there about their modified diets or their assistance. So it's in their service plans already, but it's potentially not on their banners. So that would be my recommendation, to start putting in the banners. And as Jerry said, they're working on what we call a form now. She's still used to the observations, but we would not do an observation any longer. We would do a form in senior living. And so that would be up and coming, and that would be our assessment tool, would be under the form section. And then we can decide if we want to link that to the evaluation in the future. And then I see we're running out of minutes here. So a fast reminder, since we only have 3 minutes, don't forget to run your reports often for compliance and for mischarting on your care. So your to-do list has a report for mischarting under facility and then reports. And don't forget, it's under the POC, and it is linked. There's only 2 reports for senior living under POC. So the point of care compliance will be your to-do list for compliance and charting, and then your point of care extra services is your extra service. You do want to probably run this weekly so you can go through it and decide which services are truly extra and get that over to billing, so it's not so much at the end of the month. Our recommendation is really weekly because it does get to be a lot. But compliance is really important. And also, if you want to check your EMAR compliance, you would come over to EMAR, and there's administration compliance report here for your EMAR. I don't track your EMAR compliance, but I will check your compliance with your to-do list from senior living. And of course, if you need help helping you find those reports, everyone I think has my phone number. And is there any questions coming up on senior living or the elite side for?
No, I think we're good.
Okay.
Thank you, Linda. So just in the last minute, I just wanted to give a couple of reminders. So in North Dakota, you were invited to a meeting on I'm looking at the date here, on May 4th and May 5th. So the afternoon of the 4th is going to be more just kind of general housing information. And then the 5th is going to be the deep dive into Matrix for North Dakota, and what can we do to make it better now that it's up and running and everybody's using it. So again, as you look to be, as you've been invited to this meeting, it's going to be at St. Gabe's. The first day is again kind of more deep dive into the standards, probably applicable to the housing team in general, where the next day is a deep dive into Matrix. So again, administrators, you can decide your role in that piece. And then another reminder is that you got to hold the date if you are in Minnesota for the afternoon of the 16th and the 17th. So if you are an executive director in Minnesota and you are stepping out of the ULT, please plan to stay another night. If you are a housing person, please plan to come into town and be available the afternoon of the 16th and all day of the 17th. This is going to be the deep training and prep for the new housing assisted living information. And that's all I have for today. Any questions? All right. Well, I thank you guys for everything. Enjoy your first week of spring. Thank you, Linda. Thank you to everybody and have a great day.